Today, I'm bringing you an interview about a specialty that, as a PA or an NP, you probably didn't know was an opportunity for us to work in. I'm talking about radiology. Now, not interventional radiology, that is a actually different specialty. This is radiology, straight up radiology. And I was so excited to find out that this is also a specialty that really lends itself to PA and NP entrepreneurship. There are tons of opportunities to set your own schedule, to demand high compensation. We can be masters of our own destiny in this specialty. And on top of that, this specialty is slated to grow astronomically. So you definitely want to pay attention to this and learn about the specialty of radiology. Hi, it's Michelle with the Medicine Couch. I love learning about all the things that PAs and NPs can do. It never ceases to amaze me. If you also like what I do and you want to help support the channel, please hit that subscribe button and share these videos with your friends and colleagues who may find them interesting.
Hi, I'm Jill Cook. I'm a radiology PA, and I've been a PA for 3 years. I've been in radiology for over 20 years. I began my journey in interventional radiology, and I moved quickly just into more of a radiology focus, and that's where I practice now.
Let's talk about first, like, what is radiology versus interventional radiology as far as PAs and NPs go? Like, what's the difference?
You're right. Most PAs don't even realize that the specialty exists and that it is exclusive from IR. There is some crossover. Interventional radiology is really based upon doing procedures that are intervening for the patient, either put metaports, dialysis catheters, and that's just a small focus of what they do, but they're really intervening for the patient and some diagnostic work as well. In radiology, we focus more on the diagnostic work of it, using a lot of fluoroscopy, a lot of ultrasound guided procedures. Of course, those things can be utilized in IR as well, but we're mainly focused on the radiology portion and hospital coverage as well as outpatient coverage as well for patient care. A lot of IR is more, in hospital and inpatient care.
And we're going to talk about that a little bit more as the interview goes on, like what exactly you do. And it should be clear how this differs from interventional radiology. But is this something exclusively for PAs, or is this something NPs can move into as well?
Both. I work and have trained both NPs and PAs, so it's definitely not exclusive to PAs.
Are there things going on in medicine right now, reasons why this specialty is actually kind of opening up for PAs and NPs now?
Yes, actually, Michelle, there's a huge reason, and that's called teleradiology. Radiologists are choosing to stay at home. And there is an over 20,000 radiologist shortage in the United States. These radiologists are so in demand, they're leaving groups just to do teleradiology. So with hospital coverage, you're contractually obligated, the radiology groups, to provide inpatient services and outpatient services, diagnostic procedures, GI studies, things like that. In order for them to read the exams, they have to provide these services. So with the outflow of radiologists from practice in hospitals and clinics, you have that void to fill now. And as PAs and of course NPs as well, we are highly trained to fill those positions and provide those services in a very efficient way.
Nothing happens in a vacuum in medicine, right? One
No, it
thing
does
changes
not.
somewhere else, yeah, and then something else needs to adjust to it. So yeah, that's interesting and exciting to know that there's
Mm.
another field that's really starting to open up to us more. Of course, we're probably going to be hit with the scope creep argument,
Always.
even though it's physicians that are choosing something better for them, and there's a void, right? And so
Mhm.
we're there to fill it. So let's talk more about getting understanding about what you actually do in radiology. So can you kind of walk us through some of the typical things that you do, like what your general duties are on a daily basis?
50% of my day, I have certain procedures scheduled. Some days are fluoroscopy, some days are ultrasound guided. These include GI studies like barium swallows, barium enemas, upper GI studies, and then even hysterosalpingograms, which are OB and pregnancy related studies. I do ultrasound guided biopsies. Then I do provide outpatient coverage as well, depending on the day, providing those services at offsite clinics as well. When I'm not busy doing procedures, I'm either looking at patient exams, previously approving biopsies and procedures that are coming in ordered by doctors. And because I have a strong ultrasound background, I was an ultrasound technologist for 20 years prior to PA school. I also read ultrasound examinations or give preliminary interpretation, something that we're allowed to do under our license. And then the radiologist quickly reviews it and signs off, saving them on average 60 to 90% of their time at task on these. So it's really advantageous for them and myself, very lucrative in that respect as well. I also read bone density imaging.
Yeah, that brings up all kinds of questions that I have, that I'm sure other people do too.
Uh-huh.
First of all, we'll start with the reading side. So, do you only read ultrasounds? Is there any other imaging that PAs and NPs can read?
I only read ultrasound and DEXAs. And of course, they're preliminary interpretations again, something that we're able to provide with our scope. If a PA or a nurse practitioner had a prior history, extensive history in performing CAT scans or X ray or anything in the ART or rad tech world, there is definitely opportunity for them to expand on that and provide those interpretation and services for radiology groups as well.
The preliminary reading of pretty much any imaging is within our scope since it's preliminary. It just depends on
Mhm.
how much training and experience you have in those different kinds of imaging when you come in, is kind of what determines that.
Exactly.
Then on the procedure side, is what you're doing procedure wise different than what they do in interventional radiology?
Sure. So there is some crossover. However, interventional radiology really is limited on their GI fluoroscopy. They're typically in their own interventional suite, can be on a different floor, completely separate from a radiology group. Most hospitals are now employing them separately. So they have their own list of procedures they do. In radiology, we do a lot of GI fluoroscopy. This is live x ray with fluoroscopy. That is typically not done in interventional at all. Other than that, ultrasound biopsies, those can be performed in interventional, one of those crossover things. However, depending on your background, again, mine is strong in ultrasound. I typically do all of those, whatever's better for the patient.
And obviously you're going and interacting with the patients when you're doing these diagnostic procedures, but I'm curious, do you like follow patients? Do you ever round on patients or have recurring appointments with them?
So if the patient is an inpatient, and an in-house doctor orders an exam, I definitely round on the patient. I meet with the doctor, talk to the patient, discuss our findings, look up lab work, like anything that you would typically do in-house in a hospital setting. Our outpatient procedures, such as ultrasound biopsies, myelograms, different things like that, I follow the patient with pathology. So once that pathology is back, I either provide the report with results and then follow up with the doctor, or if the doctor wants me to follow up with the patient, which is relatively rare, but it does happen, I do that as well. If a biopsy is non-diagnostic because something was so small, I do see the patient again, but typically I'm not their primary care or their ordering provider, so that's referred back to them.
So it sounds like a mix of lots of things in this job, like a mix of procedures and a mix of administration work, a mix of
Mhm.
being face to face with patients or communicating with patients, and then a mix of not, just being behind the scenes and stuff. Interesting. So if somebody's interested in radiology and they've been looking at interventional radiology, why would you suggest that maybe they think about this radiology instead of interventional radiology?
I think there are a few distinct differences that you as a provider are looking for that make radiology a better fit than interventional. And having done both in my career, I can honestly say that interventional radiology is it's a high stress job. You're typically the only provider in the surgical suite and your adrenaline is running. If you want that, that's probably, great for you. For me, I really thrive on patient care and helping patients through things. Not that interventional radiology PAs don't do that, but that's where I thrive. And so, in the radiology part of it, my goal is to meet with the patients, calm them down, talk to them, try to help diagnose what they're going through. And I just find the procedures and the patient interaction to be more empathetic based. I don't care to have that high adrenaline in the surgical suite anymore. So this was a really good fit for
Mm.
me. And also, if you have imaging background, radiology is a great fit for you. You can be taught, a lot of different areas can be taught, but if you have that imaging background, there's so much opportunity for you here.
Yeah, so is it fair to say that more of the IR procedures are like higher stakes procedures? More can go wrong necessarily, or when you say adrenaline pumping, is that what you mean?
Yes, I definitely, I've
Yeah.
been in those situations myself or been with doctors who have been in those situations. There's wonderful autonomy in either side, radiology or interventional, but I think IR is a higher stress. Yeah, definitely more things to be concerned about there.
So, when you were talking, I was also curious about what setting you work in because you talked about inpatient and
Mhm.
outpatient. Are you based in the hospital, and are most people who work radiology, do they office in a hospital or do you office outpatient? How does that work?
So half of my time that I spend reading, I have my own computer system at home. So I am able to be offsite. I read from home, which is wonderful for me. There's a lot of flexibility in that. And then the other half is spent probably 50% in the hospital setting and then 50% providing outpatient care. So hospitals typically have ambulatory clinics as well that we provide care. I'll do GI floral studies on Tuesdays at this office. And then, for half a day, I do arthrograms at this office or something like that. So it's a good, you get to move around a lot.
I love that kind of flexibility. And so, with that flexibility, do you also get flexibility in your schedule? I mean, it sounds like you do, but how does that work? And this will probably lead into where we're going to go. Like, are you employed with a group? Or are you self-employed? How does that work?
I began my career employed with a group, with a private radiology group. That group is now disbanding because everybody's going to teleradiology and moving around. So there was a great amount of radiology groups that contacted me with what I do just from word of mouth. So I actually started my own company of radiology procedural services and of course reading. I do training as well. So now I am self-employed as of January 1st. Very excited. I'm booked. So I was booked within probably a week. So
So that's exciting that you're branching out and going on your own and starting your own business. I highly encourage that for PAs and NPs to think about that we can be entrepreneurs. There's lots of things we can do, just like physicians branch out and become entrepreneurs. But I am curious if you are employed with a radiology group, so not doing your own business, but being employed with them. Do you still have that flexibility and schedule usually when you're employed in a group?
I think it would depend on whether you were directly employed by a hospital, who sometimes they do, directly employ radiologists themselves as well. I think there is more flexibility in radiology groups because they're so desperate for just help. You take advantage of that desperation and make the schedule that you want because that's what I did, and I see it happening also. Not to exploit it, but it should work for you also.
And just to follow up on that schedule, like, is this something that they have to have staffed 24 hours a day?
Typically, no. Hospitals typically require radiology coverage from 8 to 5, 9 to 4. They
Okay.
like to have that coverage then. Something that we didn't talk about that is a part of this, now that you mention that, is contrast coverage. So with contrast coverage, whenever radiology is using CAT scans, MRI, anything like that, they require somebody to be on site, PA, NP, or physician, in case of a contrast reaction, anaphylaxis or anything. They have to be able to manage that. So that is one of the things that they require. And again, something that can be very flexible because outpatient facilities can flex that time or schedule patients according to your availability. And that's
Mhm.
pretty advantageous as well.
What are some of the things that have been a surprise to you in this specialty or things that you really love?
So one of the coolest things I think about being a radiology or interventional PA is the fact that you are typically one of the highest credentialed PAs or NPs in a facility. So having to be able to perform literally every type of procedure that probably comes through the door besides cardiac, you are credentialed for all of those things. So becoming proficient and knowing you're able to do those things and that people respect you for that education and knowledge is just a really great feeling. You just really feel like you belong in your profession, and it gets rid of that what is that, imposter syndrome real quick after, because you're doing these things and doing them efficiently and being recognized for that as well. I really, really enjoy that feeling. Another thing that I really love is the flexibility of the time, being able to read from home, and that really provides some good work-life balance. And another thing that is so important to me is the patients that we generally see, especially for biopsies, GI procedures. These patients have been going through a lot. This isn't the first time they've typically been here. Some of these GI patients have had problems for 6 months, a year or more, and can't get down to what's causing their symptoms. working with those patients, making them feel comfortable, and just that, again, that empathy, really expanding on that empathy with them. I love being able to take that time because I don't have a time limit. I don't have to see patient, 15 patients in, a certain amount of time. I love being able to spend that time with them, calm their nerves and explain things and helping them understand. We're so rushed in medicine anymore that these patients don't understand what's happening to them, why they're having these
Right.
procedures, and what the cause can be. I had the opportunity to slow that down and explain things and get them to a better place, at least until we get results. So I really enjoy that.
How many patients a day are you seeing typically? Or like if you're doing procedures, how many are you end up doing a day?
It depends on the day and what I'm doing. Ultrasound procedures, biopsies are scheduled one every hour, and I'll do those one day a week. GI procedures are scheduled typically one every half an hour, depending on what type of GI study it is. And I can do those all day long. So I have a good amount of time with these patients and to get things right. And
Every specialty has its upsides and downsides. What are some of the challenges or downsides to working in radiology?
the biggest downside right now is there aren't enough providers. We've been trying to recruit for PAs and NPs and everything with a radiology background or even an interest in it, but nobody knows what it is. So it's been very difficult. In addition to that, the lack of radiologists on site. You have to have radiologists on site to train. So even though I can train, I feel very proficient at what I do. I'm one person. So
Okay.
it's been very difficult. They've got the cart ahead of the horse, and that now there's very few people, honestly, it really is. There's very
Okay.
few people on site to provide this training that's so necessary right now.
Yeah, that is an issue. And I was thinking about that earlier when you're talking. How closely do you work with radiologists? I mean, even if they're radiologists from home, like, are you constantly talking back and forth, or is it just kind of some messages exchanged here and there? How does that work?
I'm in almost constant contact with my radiologist throughout
Okay.
the day. With hospital credentialing, most hospitals, depending on their bylaws, require, I have to have someone that I can talk to or video conference if I have questions. So if I have questions or even my exams that I'm reading, we're texting back and forth. So I have communication. It's just I don't have on-site help. And so it can get busy,
So you talk about that it's difficult to get training. So it made me think about how much experience people need to come into this specialty with. You kind of hit on it a little bit, but say somebody has an interest in this specialty. They're watching this and they think that sounds, pretty cool and something I would like to do, but they don't have a strong radiology background per se. What do you think about that? And like what kind of training is usually included when people come on board to radiology?
Typically, when you're coming on board to radiology, people have minimal experience. So it's difficult because there's not a lot of time to train in between procedures to understand fluoroscopy. Fluoroscopy, again, is radiation, and you really need to be careful with your doses and know what you're doing with that. It just takes time. And like I said, unfortunately, the radiologists are typically reading. This is what their incomes are generated off is reading. If they have to step away from their computer, that's taking away from their income. So they don't really appreciate that so much. And I wouldn't either, I assume. So I think training is just, being able to get the time in and finding somebody who is proficient at it to be trained the appropriate way.
And I assume if somebody is already in interventional radiology, that they have some of that training already. Is it easier for them, or do they not work with fluoroscopy and have to go learn that anyway?
It would be easier. If somebody's been doing interventional radiology, you do use fluoroscopy. I use
Okay.
fluoroscopy quite a bit there. I actually learned about dosage and the importance of minimizing those doses and how to do so appropriately use fluoroscopy when I moved into radiology primary
Oh,
focus,
good.
I should say. There's a difference, but interventional radiology is really lighter use of fluoroscopy. It's not as long for PA standpoint.
But that's a good springboard, or somebody's in IR and they want to get out of
Absolutely.
the high pressure, but they
Yeah,
still like doing some procedures, still like radiology. This might be a perfect fit for them.
I would agree.
Yeah. So, what about salary then? Like, how does the salary for radiology compare either to IR, or just if you could just give us some kind of range or idea of what the salary is?
It depends on whether you work again for a hospital system or a radiology group and what you're doing. So take advantage again of that shortage of radiologists, and they have to provide this coverage. It's really dependent upon your negotiation skills. I believe your necessary radiology is a necessary component of coverage. So we get pretty high rates for interventional radiology. For radiology itself, I make more now as a radiology PA than I did as an interventional PA. And you're talking about the mid to higher $100,000. So, and I you're going to start off at probably 120 at the low range. Again, the more you read, the more you do is going to determine that. Reading examinations, the ability to is very lucrative.
Which is why the physicians want to just sit at home and do the readings,
Mhm.
because that's the higher reimbursement part than the procedures, right?
Absolutely.
So how would someone go about finding this position and or advocating to create it for PA or an NP?
I think just being more knowledgeable about it and then asking radiology groups. You can look up on the internet local radiology groups and sift through them. Even the radiology groups themselves don't realize the ability for PAs and NPs to help them out. And they're just now discovering this. Like I said, from word of mouth, just from the doctors that I've worked with telling other doctors, I was booked within a week because it was just like they could do this. They can wait. What do you mean? We can stay home? So it was just, it's this eye opening, so it was very, I think just the awareness and opening that up. I know when I was first asked by this radiology group to join, it was a group I had worked with previously as an ultrasound tech. And I said, hey, I would love to do this for you when they ask. And I said, but I want to be able to read ultrasound. I want you to give me that opportunity and see what you think. So always remembering what you're good at and a way that you can maximize your abilities and also advance the profession in a different way. Like let me give you a
Yeah.
try. Let me try this for you. And now it's just I didn't know she could do that. And everyone
Right.
has that ability. Find what you love and just do it.
I say that all the time in your practice. If there's something you love about your practice,
Mhm.
find some way to make that like the majority of what you do on a daily basis. As you were talking, I was also sitting here thinking we need to realize that we're kind of in the catbird seat in this particular specialty right now. This is the opportunity for people to really kind of set themselves up, flexibility on schedule, to advocate for higher pay because, like you said, this is something that's needed. There's a big void right now, and we have the opportunity to step up and fill it. So I think that's really cool and exciting. I love to hear that. And so, do you think that this is something that is particularly suited for PAs or NPs to be their own boss, to be entrepreneurs in this space?
Absolutely. I really do. The tricky thing is having a collaborating physician. So with my contracts that I have created now, the groups that have wanted to employ me, I'm not employed by them. I'm a 1099 employee. However, my collaborating physician agreement is with each group. So I have physicians that have signed off on this and then they do all of the billing, everything. I don't have to worry about any of that. So there's very little overhead. They're billing for everything. They're my collaborating physician. They are paying for my malpractice insurance, literally everything. And this is such an I don't want to say easy thing because you have to have the training, but once you have the training, the opportunity for
Yeah.
self-employment, entrepreneurship is just really great.
So the advantage of doing that is mostly found in your schedule, your ability to be flexible. Is that the biggest advantage that you found being the entrepreneur instead of being employed directly by the group?
It's more lucrative, so I
Okay.
can command pretty much what I want, and they
Okay.
they respond in kind because they have to have this. Obviously, not an exorbitant amount of money, but so there's a financial advantage. Of course, I can make my own schedule as well within
Yeah.
reasonable time. I get to work from home sometimes, and I really get to decide, no, I don't want to do those things. Those things I don't feel
Yeah.
comfortable with, or if you can't provide me training, then you put it all in your contract. Yeah, there's a lot of flexibility there, and it's just really great to be a PA who owns her own business now.
And I'm so happy to, for you. And I really hope that people take this to heart and think about how they could become their own boss as well.
Absolutely.
So we've kind of hit on it a little bit, but just how do you envision this specialty growing for PAs and NPs? Do you think it's going to be something that's going to become a larger, more recognized specialty?
As the awareness grows, I think the sky's the limit as far as the growth opportunities for NPs and PAs. The more people that we can get trained in radiology, obviously, the more this is going to expand. This is a countrywide, a global wide problem, a lack of radiologists. And even if you had 1,000 radiologists that graduated tomorrow, you still would not fulfill the need. And they're still going to want to read from home. So
Yeah.
the advantage here, gosh, there are so many advantages and there's so many opportunities for growth. There's a lot of different pathways.
It is exciting, but then the thought popped into my mind because I see it a lot in headlines and things I'm looking through is that radiology tends to be singled out as one of the specialties that will be replaced by AI sooner than other things. What are your thoughts on that? Do you see that being an issue in the future?
That's a big discussion in ACR, which is the American College of Radiology. And it's been a consensus by everything that I have read and spoke with my own physicians that there isn't a fear of AI taking over. There's definite ways that it can help and increase efficiency, but radiology really requires a physician's eyes, a PA's eyes, a trained NP's eyes. You have to have a physical set of eyes on this imaging. I would want that. And ultrasound is such an operator dependent thing, so going to alleviate some of that burden, but certainly not take it away.
So I wonder if there are resources that you would recommend for people, whether it's books or different societies, podcasts, anything that people can kind of tune into if they're interested in this to learn more about radiology and the specialty.
The first thing that comes to mind is radiology assistants. These are assistants to radiologists, as the name implies.
Which is
Their
why
website and their
that we need to
society.
change the name to physician associates or something else because, people hear radiology assistants, you think assistants to the radiologist, physician assistant, assistants to the physician. Anyway,
Oh,
sorry to
gotcha.
interrupt your thought there.
Oh,
I
I
just
see what
thought
you're
that was
saying.
perfect to explain why
100%.
it's such an issue and a problem to be a
100%.
physician assistant when that's
Absolutely.
not what we do anymore, really. So anyway, you were talking about radiology assistants, and were you suggesting that people looking to become a PA in the future and do this could start off by getting their experience with radiology assistants? Is that what you were saying?
Yes, I think either in radiology technology, ultrasound technology, radiology assisting, those are all great areas to move into before PA school, possibly, or even look into to get more information about what radiation actually is and what ultrasound actually is. And of course, the American College of Radiology with the ACR, that's the governing body for radiologists. And there's tons of information on there as well. Really grasping the idea of radiation, radiology, and whether or not that's the right avenue for you.
And if somebody's already a practicing PA, are there courses that people could do like online after work or in their spare time?
Yeah, there are courses, CME courses that you can take. The ones that I have found are relatively dry. So it could make you, it could give you the false idea that this is really boring and it's a lot of math or it's a lot of figuring out. And it's not. So it's not. But there's definitely CME courses on AAPA and probably your state societies as well. And then just even, YouTubing different procedures and finding out if you would like to do
Yeah.
things like that. There's so many resources out there.
You mentioned earlier that in your business that you also train PAs and NPs. Can you tell us more about that?
My business is contracted to go into PA programs and train for ultrasound. During that time, I also try to make a large awareness about radiology PAs and see if anybody's interested. I also am hired by radiology groups to come in and actually train their NPs, PAs to perform these procedures or become a radiology PA. So that's been lucrative as well. Another thing that I train with is that I'm starting to next year provide rotations in radiology for PA students. So this is another way to, awareness and trying to really get those PAs with some radiology background, some exposure to it.
Yeah, because that needs to happen, right? It's hard for people to know if they like something if they can't get a little taste of it, which is why I do these
Absolutely.
interviews for people who
Yes.
can't get those rotations. So it sounds like even more flexibility on the entrepreneurial side if
Mhm.
you don't want to constantly be working doing the actual work, maybe you could do that part-time and then line up teaching because I imagine that there's also a limited number of PAs and NPs out there doing teaching for radiology and ultrasound and
Mhm.
stuff. So there's probably a good market there as well. All right. Well, this has been very illuminating. Thank you again for joining us.
Thank you so much, Michelle.
If you want to learn more about interventional radiology, then watch this video here. Or if you want to learn about other PA and NP entrepreneurship opportunities, then click on this playlist here. Thank you for watching. As always, take care, stay sane, and I'll see you next time on the Medicine Couch. Bye.